So, the brain's frontal lobes, they're really the seat of our personality, aren't
Yeah.
they? Our judgment, our whole social operating system.
That's right. And when that system starts to fail, what we talk about as frontal network impairment or FNI, the symptoms are, well, they're devastating, but also incredibly confusing.
Yeah, confusing is the word.
It's like the ultimate diagnostic chameleon, really. You see things like disinhibition, um, profound apathy, or sudden really poor judgment.
Hmm.
And these symptoms look so varied. Plus, they overlap almost perfectly with a whole list of primary psychiatric disorders.
And that overlap is, well, it's the core trap, isn't it? Frontotemporal dementia, FTD, particularly the behavioral kind, bvFTD.
Right.
It's a major cause of young onset dementia. But it looks so much like a psychiatric issue at first that, people often wait 5 or 6 years for the right diagnosis.
5 or 6 years, think about that. That's years of potentially wrong treatments, misdiagnosis, families completely confused and
Yeah.
struggling. So what we're doing today is trying to cut through some of that confusion. We're using real-world data, looking at a deep dive into this retrospective study from a specialist clinic down in Melbourne.
A cognitive neurology service.
Yes, exactly. Over a decade, they gathered data on 161 patients. And these were patients referred specifically because the doctors seeing them suspected FTD or this general FNI picture.
And this wasn't just any clinic. We're talking a specialist referral center. The really tough behavioral cases ended up there.
That's the key point.
So our mission here is to unpack that. Who actually got referred? After all the tests, what diagnoses did they actually get? And maybe most importantly, what were the clues? The few things that finally helped tell the difference between real bvFTD and a primary psychiatric disorder.
Okay, let's get into that mix. First, just understanding the group. The 161 patients, they ranged in age from 42 to 82, but the average was around 64, mid-60s. And they were referred for those classic frontal behaviors. We mentioned personality shifts, maybe getting really disorganized, losing empathy, apathy, that kind of thing.
And the clinic itself, you mentioned it has a bit of a bias.
Yeah, they tend to see younger people where the main issue is behavior or sometimes language rather than, say, memory loss like in typical Alzheimer's.
Right. So these are often people who've maybe bounced around the mental health system, perhaps just labeled difficult or going through something.
Quite possibly.
So given it's a specialist FTD clinic, you'd expect, logically, most of these really tough cases would end up with an FTD diagnosis, right?
That's definitely the logical expectation.
Yeah.
But the reality just shows how complex FNI truly is. It's staggering when the whole team did their comprehensive workup.
Yeah.
FTD syndromes, and that bucket includes bvFTD, semantic dementia, PSP, those sorts of things. They only accounted for 44.6% of the final diagnoses.
Hold on, just under 45%. So if my math is right, that means 55%, more than half, were something else entirely, even though they were sent there for suspected FTD.
Exactly. That number just jumps out, doesn't it? It confirms how incredibly challenging this patient group is.
Wow. So what were the other diagnoses then?
Well, bvFTD itself was the single most common final diagnosis at about 26.7%, so roughly 1 of 4.
Okay.
But the very next most frequent diagnosis, primary psychiatric disorder, PPD, that was 15.5%.
15%. Referred to a specialist dementia clinic presenting with frontal symptoms only to get a PPD diagnosis in the end. That explains so much about the delays.
It really does.
Yeah.
And it wasn't just those two. You also had significant numbers with vascular cognitive impairment, VCI.
Yeah.
That was about 10.6%.
Okay.
And even Alzheimer's disease, almost 10%.
So you've got this behavioral ambiguity, these frontal symptoms, and they could point to bvFTD, PPD, vascular issues, even AD. If you're a clinician seeing that patient early on, where do you even begin to untangle it?
Well, you begin where they all started in this study, with the standard screening tools. And that's really where we need to talk about what doesn't work.
Right.
Because those initial common tools, they often fail completely in this specific situation.
That's a really crucial point. Because we're sort of trained to think of cognitive screening, the MMSE, the mini mental state exam, or the ACER, the Adam Brooks cognitive examination.
Yep, the standard ones.
We think of them as the first step, the gatekeepers for dementia diagnosis. But this data, it says, what?
It says quite clearly that the total scores on these standard tests were pretty much identical. There was no significant difference between the group that ended up with a bvFTD diagnosis and the group that got a PPD diagnosis.
Wow, so using those common pencil and paper tests to try and filter out a psychiatric cause from an early dementia cause.
It just won't work reliably in this context.
Yeah.
They simply don't capture those subtle frontal executive changes that might be happening in early bvFTD well enough to distinguish them from someone with a functional psychiatric illness who might also struggle a bit under testing conditions.
That is so counterintuitive and a huge takeaway for anyone working in primary care or initial assessments. Okay, so the basic cognitive screens are out. What about the patient's history? Surely, if someone has like a 20-year history of depression or anxiety, that's got to point strongly towards PPD, right?
You'd absolutely hope so. It seems logical. But again, the data here really throws a wrench in that assumption.
Right.
Overall, having a pre-existing psychiatric diagnosis was incredibly common in this whole group. For F&I, almost 45% had one.
Nearly half. Right.
But here's the kicker. When they look specifically at the two groups we're most interested in, the bvFTD patients and the PPD patients,
Yeah.
there was no significant difference in how many years total they'd carried a psychiatric diagnosis.
They just sense it all.
There's none that was statistically significant. So whether you ended up having bvFTD or a PPD, you were just as likely to have a long, complicated mental health history on paper.
So that history, it's basically useless for telling them apart. It's just that becomes background noise.
Essentially, yes. In this specific comparison, it didn't help discriminate.
Okay, what about age? We know bvFTD is young onset, but so are many psychiatric disorders. Did age help?
Not really for separating those two key groups, no. I mean, yes, the Alzheimer's patients in the study tended to present later, average onset around 68.
Right.
But between bvFTD and PPD, the average age of symptom onset for bvFTD was about 58, and for PPD it was about 56 and a half.
Very close.
Very close. No statistically significant difference. Both conditions are hitting people relatively young, often, when they're still working, raising families.
Which just makes the diagnostic confusion even more urgent and impactful. Okay, so let me recap. We've got two groups, bvFTD and PPD. They look similar behaviorally, at least initially. They score the same on the standard cognitive tests. They're just as likely to have a long psych history, and they start around the same age.
That's the frustrating picture.
This is where it gets really interesting then, the detective work. What factors did finally start to pull these groups apart? What actually worked?
Okay, this is the aha moment territory. There were two critical factors that emerged, and they were kind of outside the usual neuropsych toolbox.
Oh, okay.
The first one was general medical health.
Medical health. You mean like blood pressure, diabetes, that sort of thing?
Exactly. Specifically, they used something called the Charlson Comorbidity Index, the CCI score. It's basically a way to tally up serious medical conditions a person has. Things like, diabetes, significant heart disease, kidney problems, certain cancers.
Okay, a measure of overall physical illness burden.
Precisely.
Yeah.
And what the study found was that the CCI scores were significantly higher in the group eventually diagnosed with bvFTD compared to the group diagnosed with PPD.
Wait, higher in the bvFTD group? The ones with the neurodegenerative disease had more other medical problems? That feels backwards somehow.
It does seem counterintuitive at first glance, doesn't it? You might think the PPD group, maybe through lifestyle factors sometimes associated with chronic mental illness, might have more issues.
Right.
But no. The bvFTD group had the higher burden of systemic medical illness. And the researchers think this might actually support some newer ideas.
Like what?
Well, there's growing evidence from genome-wide studies suggesting genetic links or overlaps between things like autoimmune disorders, inflammatory conditions, and the FTD spectrum, even motor neuron disease.
Ah, okay. So it hints that maybe bvFTD isn't just purely a brain disease isolated from the neck down. It might be part of a broader systemic vulnerability, maybe involving inflammation.
That's the hypothesis, exactly. So suddenly asking detailed questions about someone's general medical history, tallying up those comorbidities, becomes potentially more useful for differentiating in this specific context than doing a standard cognitive screen.
That's massive. A real paradigm shift. Okay, so systemic health is one key differentiator. What about the behavior itself? You said the general behavioral picture was confusing, the overall scores on standard screens didn't work. But was there any tiny specific behavioral detail that was like a smoking gun for bvFTD?
There was, and this is maybe the most practical actionable clinical takeaway from the whole study.
Okay, I'm listening.
They used a very detailed questionnaire filled out by the caregivers. It's called the Cambridge Behavioral Inventory Revised, or CBIR. Now, the total score on this detailed inventory still didn't cleanly separate the groups.
Still didn't work overall.
Okay, one very specific subsection did. It was significantly higher, statistically speaking, in the bvFTD group compared to both the PPD group and the vascular cognitive impairment group.
One subsection was the key. Which one?
Eating behaviors.
Eating behaviors. That seems so specific, almost mundane.
Mundane, but apparently incredibly potent as a diagnostic clue in this context.
What exactly are we talking about here? Just eating more?
It's often more specific, sometimes quite bizarre changes. Things like a really marked increase in appetite, developing strange food preferences especially, and this came up a lot, a fixation on sweet foods or carbohydrates.
Oh, the sweet tooth phenomenon.
Yes, or maybe developing rigid preferences, only wanting one type of food. And also, sometimes, a noticeable decline in table manners, things that the caregiver would definitely notice as a change.
So think about it from the family's view. They see their partner, who used to be, quite normal at meals, suddenly exhibiting extreme gluttony, maybe hoarding food, or starting to eat with their hands when they never did before.
Exactly, those kinds of specific changes.
And the specificity is what makes it useful, right? Because general apathy or being a bit disinhibited, you might see that in severe depression, maybe other things.
Correct.
But the person with early bvFTD is the one who suddenly can't stop eating cookies or insists on only white bread and jam, while the person with PPD typically isn't showing those specific changes related to eating mechanics or preferences.
Precisely. And changes in eating behavior are actually a core clinical diagnostic criterion for bvFTD, but maybe they get overlooked sometimes if you don't ask specifically. This study really hammered home that clinicians have to ask the caregiver directly about these things.
Don't just ask, how's their appetite? Ask, have you noticed any changes in what they eat, how much they eat, or how they eat?
Exactly. That detailed, structured behavioral interview focusing on these very specific areas that the broad screens miss turns out to be much more discriminating than just checking mood or doing a quick memory test.
Okay, so given how unreliable the standard stuff is, the cognitive tests, the psych history, and how subtle yet crucial these differentiating factors are, like the CCI score and the specific eating habit, it feels like the final diagnosis really relies heavily on the later steps, the advanced imaging, the multidisciplinary team review.
Absolutely. It underscores why you need that full MDT approach.
Yeah.
Neurologists, neuropsychologists, maybe speech pathologists, geriatric psychiatrists, everyone looking at the whole picture. Because the imaging does help distinguish. People with PPD or VCI or AD generally do look different from those with bvFTD on structural MRI scans and especially on functional scans like FDG-PKT.
So even if the outward behavior is tricky, the underlying brain changes often show up on the scans.
That's generally true, yes. The pattern of atrophy or metabolic change can be quite distinct, but
access is an issue.
access can be an issue, cost can be an issue, and sometimes even in early stages, the scans might not be definitively abnormal yet, which is why the field is moving rapidly towards fluid biomarkers.
Things like spinal fluid tests or blood tests.
Exactly. The source material specifically mentions things like neurofilament light chain NFL, which you can measure in CSF or even now in blood plasma. These markers of nerve damage are proving very helpful in separating neurodegenerative processes like bvFTD from primary psychiatric conditions.
So that could speed up diagnosis significantly, especially important if we start getting actual disease-modifying treatments.
That's the hope. Faster, more accurate diagnosis is key.
And just circling back to the behavior piece for clinicians on the ground, the big message seems to be, don't rely only on those broad screens or just the presence of a psych history. You absolutely need that detailed caregiver interview.
Yes.
Focusing laser-like on the specific behavioral changes, like those really telling eating abnormalities, that the standard tests completely miss.
That's the clinical takeaway. This study makes it crystal clear. When the main problem presenting is behavioral change, the usual diagnostic pathway can be really obscured. You have to bring in the full picture, the person's general health, those nuanced behavioral changes over time, and increasingly advanced imaging and biomarkers to really cut through that F&I masking effect.
Okay, let's try and consolidate this deep dive because it's crucial stuff. If you're faced with someone showing these frontal network symptoms, your standard cognitive tests, even a really long, complex psychiatric history, probably not going to help you tell bvFTD apart from PPD. They're surprisingly useless for that specific distinction.
Right. They fail right there.
Instead, the real clues, the things that did help in this specialist setting, were looking at the person's overall physical health,
Mhm.
using something like that Charlson Comorbidity Index.
Mm-hmm. Higher scores leaning towards bvFTD in this study.
And then getting super specific with the caregiver about behavioral changes, especially those odd or compulsive eating habits, the sweet cravings, the changed manners. Those were the subtle signals.
Absolutely. Those specific informant-reported behaviors were key, which really leads to a fascinating final thought, doesn't it?
Go on.
Well, think about it. The distinction between bvFTD and PPD is so difficult, right? We end up relying on these highly specific behavioral details or advanced biomarkers and imaging. The general picture of mental health, the general cognitive scores, they fail us in telling these apart.
Yeah.
So what does that suggest about the deep biological connections, maybe even overlaps, between what we traditionally call neurology and psychiatry, if they can look so similar on the surface?
Blurring the lines.
Exactly. And if a simple thing, relatively speaking, like asking detailed questions about eating behavior, turns out to be a powerful clue for early bvFTD, it makes you wonder, what other simple, specific questions about daily life, about habits, about subtle changes, what else might we be overlooking in our standard interviews that could be the key to unlocking other challenging early diagnoses?
That's a great point to leave our listeners with. What other simple questions hold the key? Fascinating stuff.